Thank you, Dr. Bastin and KSOS for having me in this session. And I'll be speaking about a few case scenarios where I had problems with the rhexis. This is just a video-based presentation, no written slides in this presentation. So let us start with a slightly old video of mine, which is this is about nearly 10 years old. This was a young patient with a very intumescent, cataract. But inside the lens there was no material. The moment I touched the capsule, the whole thing, split. The capsule split open with a typical Argentina flag sign. In these cases, with a very soft lens material, you can safely go ahead with a phaco. Now, whenever we see this, there is always a feeling that probably we should not do phaco. Maybe we should convert to SICS. But when you have a split like this, which is uniform in both sides, it is not a very hard cataract. You can safely go ahead and do phaco in these situations. So here what I am doing is a 3-piece lens. I am putting it into the bag actually, whatever bag is there, the 2 sides. And then once it is gone into the bag, I cut the 2 sides of the capsule and make it into what I call the hemi-rhexis on both sides. And so this 3-piece lens is well centered inside the bag. With an intact PC. Now, when you have a single runoff, the runoff can happen at various points. Okay. So this was again a slightly intumescent cataract. Mind you, when you don't have fluid leakage from inside, those are the dangerous ones. You have those, thick fibers there. So here I was not able to approach through the side port. I went through the main wound. I couldn't do it there. And by the time I tried to get another instrument to salvage, this had just cut off. So I decided because it was away from the main port. So which means my cracking maneuvers are away from the main port, and so I decided to go ahead with phaco in this situation. So if you have something that is away from your main port, it is slightly safer to go ahead with phaco. There is nothing that is absolutely safe, but if you have something that's away from your main wound, probably you are slightly more safer in going ahead with a phacoemulsification. So then you have this situation where the rhexis is subincisional. So the moment you touch the capsule, the whole thing comes towards your incision. These are the ones that I usually tend to go in for an SICS, because when you go in and crack these nuclei, your crack force is along the area of your rhexis runoff. There is a high chance that it can go into the posterior capsule and become a wraparound tear. And so in these situations, I usually prefer to convert into an SICS, whereby actually this is not a very hard cataract. This was intumescent but a slightly soft cataract, and so it was coming out piecemeal through the SICS wound. And then again the lens goes into the bag because it was a single rhexis extension. These are capsules that you come across once in a while. These are fibrosed capsules. So when you have capsule fibrosis, obviously you have to stain the capsule, but then you try to go around the area of fibrosis. So that is the key here. Sometimes you may not get, but here I was able to get a small area beyond the area of fibrosis, and I was able to complete this rhexis. And in a rhexis like this, once you've got a complete rhexis, then you are very, very safe, because the remaining part is fibrosed. Even if you have a small tag somewhere, you can actually cut it with the scissors. These are actually safe capsules which usually do not run off into the periphery. This was another young patient with a fibrosed capsule, but when you have extensive areas of fibrosis, one of the problems is that you don't get to stain the capsule properly. So in spite of putting so much of stain on the capsule, the fibrosed areas have not taken up stain, and so I am finding it very difficult to visualize the capsule here. So I make this capsule till it is halfway, then I am not able to see again. I am trying here with a micro-rhexis forceps. Here I have lost the visibility of the capsule yet again. And so what I have done is I have just gone ahead through whatever capsular opening is there. I finished the phaco, but then I found out that there was a fibrosed area here with a small tag here. So I am cutting the capsule there, extending the tag, making it into a rhexis, and then going ahead with an intraocular lens. So the message here is that in a fibrosed capsule, if usually it does not run off much to the periphery if you are very, very careful with that. Now, how do we retrieve a runaway rhexis? Now, this is a case where this is the technique that I usually do. I make a small rhexis and then with a Simco or a bimanual, I wash the cortex. But here, as I was washing, this rhexis has ripped here, but luckily it has not gone till the periphery. So, I can still see the edge here. So, I have put viscoat in the anterior chamber. You should not overfill at this point. Be very careful. If you overfill, the overfill itself will make the capsule to rip. But here the right fill of viscoelastic there, flattening the surface of the anterior capsule helps me go the other way. Normally I do the rhexis in this direction, but in some situations you will have to do the rhexis in the opposite way. If you are not doing it daily, you have to do it a bit slowly, probably even use your left hand to do the rhexis if you are a right-handed surgeon, and then the rhexis got completed here and phacoemulsification was done just like in any other case. You can have rhexis fibrosis which is hidden. So, this is a small pupil about grade 3 to 4 cataract. I decided to go in with iris hooks in this case, and once I started the rhexis, I found out that there was an area of fibrosis here. So, I then crossed the area of the fibrosis and went ahead with the rhexis completion. I went ahead with phaco, and towards the end of phaco, I realized that this area there is a large PC rent. So, wherever there is an area of fibrosis, visibility in these situations is extremely important. You have to be sure you have done a proper rhexis. That makes a big. Here, luckily, I did not have a drop. But if this was a very large, rent which had occurred earlier in my surgery, probably I would have dropped the nucleus. So, I went ahead and did an anterior vitrectomy there, and there was enough rim for me to implant a 3-piece lens in the sulcus. Although with a rhexis which is not intact, we cannot capture this lens, but the 3-piece lens goes into the capsular sulcus. Now, coming to a Morgagnonian cataract, these capsules behave slightly differently. They don't usually run off to the periphery. The Morgagnonian ones with milky fluid inside normally do not run off to the periphery, unlike the intumescent ones. So, in these situations with very hard cataracts in between, my personal choice of preference is an SICS. So, here I have just made a nick here, the milky fluid is leaking out. I am trying out with the microrhexis forceps, is again leaking out. So, I made a tunnel, I washed the fluid there, and then I used viscoat. No financial interest, but in these situations, viscoat is a very, very good tool to maintain the chamber. You can see that I go through the main wound with the utrata forceps, and then complete the rhexis. The chamber does not collapse at all. So, in these sort of situations, usage of viscoat is extremely important. And with this very hard cataracts with just milky fluid and inside, as I mentioned before, I usually prefer to do an SICS. I've tried doing phaco with a lot of flower patterns and things like that, but generally corneas are a bit hazy the next day, so I generally go in with an SICS. So, what is the ideal way to do? I generally do what is called a triple rhexis. So, you have done your first rhexis, and then you enlarge and make it into a second rhexis, and then you can go ahead with your phacoemulsification, and once you finish that, you can go ahead with a third rhexis. If you think that your rhexis is overlapping the IOL for more than a millimeter or millimeter and a half, then you can go ahead and do a triple rhexis and have a nice coverage in these cases, and also prevent capsular phimosis. Is femto the answer for all these intumescent hyper mature cataracts? Not probably in all cases. This was a femto rhexis that was done. Usually in femto rhexis, it's always better to stain in these white sort of cataracts, because if you don't stain it, you may not see small tags. So here I found that there was a small area of tag here in spite of the femto. So you have to stain the capsule very carefully, fill the chamber with viscoat, and use an utrata forceps to make this capsule into the round rhexis that we normally need. So in summary, understand the capsule physics well, understand that capsules are different in white intumescent cataracts, in hypermature cataracts, in Morgagnonian cataracts. The capsules behave differently in these sort of situations. Staining and visibility are extremely important. Chamber maintenance is very important. Use an ideal OVD. Don't try to reduce your cost by using HPMC in these situations. You do need better OVDs in some situations. You need proper instrumentations like your microrhexis forceps, your microrhexis scissors, your utrata forceps. Always have an alternate surgical plan. So in case it doesn't work out the way you want, Are you going to change the lens? Are you going to change into an SICS from phaco? So alternate surgical plans should always be in your mind. Thank you for your kind attention.
Thanks a lot, Sai. So the next lovely video, Sai. Next speaker is our own Dr.